Terrific. Thank you very much for that warm welcome, Leanne, and for inviting me to speak today. I do feel a bit like a fish out of water, I have to say, and you're probably wondering what I can say to you that will be of interest. But I'm hoping that speaking about a very well-established multidisciplinary model of care for patients with stroke might promote some thinking about how some of the things that we've learned over the years might be applied in your field, and hopefully it's a little bit interesting. So I thought I'd better just set the scene, because I can't assume that people in the room know where I'm coming from at all. So what is a stroke? What do I look after? Well, stroke is something that is a sudden onset of focal disturbance of brain function that's due to a vascular cause. And about 80% of stroke is due to blockage of an artery, but about 15% of stroke is due to bleeding directly in the brain, where a blood vessel is ruptured. And a smaller proportion of stroke is actually due to rupture of an aneurysm. Usually that's a ballooning of one of the small arteries at the base of the brain, and that usually causes a subarachnoid hemorrhage, which can present like a stroke. Now, one of our difficulties in working in acute stroke is that there are a range of other conditions that can mimic stroke. So that when you have someone presenting with a sudden onset of stroke, depending on how patients are referred to you and how your system works, up to half of the patients that are initially thought to have stroke actually have something else. So this needs to be part of your system of diagnosis that Brendan was emphasising as a very important part of care. Another aspect is that typical symptoms of stroke disable the patient and actually may prevent them from calling for help, because typically there's weakness on one side of the body. There may be difficulty speaking or thinking, and the patient who's afflicted may not actually recognise or acknowledge that there's something quite seriously wrong with them. So that can delay them seeking care and can mean that quite some time may pass before they receive care. So what about the context of stroke in general in Australia? Well, it's estimated that about 50,000 new cases of stroke occur annually in Australia, so it's a common problem. The other interesting thing that you might not know is that people of all ages can suffer a stroke. It's possible to have a stroke in utero or in perinatal time, but most commonly it's a disease of older age, so the median age is 76 years. So our clientele are generally people with other comorbidities and complexities of care. It's also something that causes in-hospital mortality. So across Australia, about 12% of patients admitted to hospital with stroke die, and about 25% of stroke sufferers are dead 3 months after the onset. So this is an important part of care. And if you don't die, about a third of patients have ongoing disability just at the level of everyday activities of daily living, like walking and transferring and getting dressed and eating your food. And if you look at more broader consequences of stroke, then these are much, much greater, looking at higher levels of function. There is an opportunity to prevent in some, because you can have a warning transient ischemic attack or TIA or mini stroke. But only about 1 in 5 patients actually suffer this, and this is often not recognised as the warning for stroke. There are known factors that increase risk, and I was interested to see Deb's slide before, because many of the things that you are looking at preventing, of course, intersect with us, and there are many opportunities for prevention. Stroke also has a sudden, unexpected onset, so the systems to deal with stroke have to be geared to act very rapidly. And the most challenging thing for us in the very acute sector is that the most effective stroke treatment, the clot-busting treatment that we can apply to people with blocked arteries, only works if it's applied very early after stroke. So we have to have a very prompt recognition of stroke and systems that allow us to deliver that care within that very limited time window. So this is the space that I live in. So you'll see a bit of a theme, but these are my slides. So I thought what we do, and I'll just go back for a second. So what we have is a very complex disease that has problems with detection and prevention, acute care, and then care in the rehabilitation sector and long-term care. And the multidisciplinary approach to managing these patients applies across that spectrum or that care journey. But what I'm going to concentrate on is that acute aspect of care, which is where I work. So we're going to tell you about this is not a real patient, but this is how things should work on the best day, and sometimes it does. So this is the Austin Acute Stroke team in action. So here's our patient at 7:30. She's got up out of bed well, and she's been having her breakfast with her husband, and her husband sees that all of a sudden she has right-sided weakness and she can't speak normally. Now, the important thing is that he has seen the public health messages about stroke that you may have heard, the FAST campaign, face, arm, speech, time, and he knows that he should ring the ambulance. And he's very good. He tells the ambulance dispatcher that he thinks his wife has had a stroke. Now, the ambulance recognises that having a stroke, and this sounds like a stroke to the ambulance dispatcher, is a very urgent thing, and he needs to dispatch the ambulance, lights and sirens. So off the ambulance comes, lights and sirens, arrives at the patient's place and is wanting to take the patient as quickly as possible to a stroke-prepared hospital, which happens to be the Austin. And they also know, because we have an agreement about this and we have involvement of ambulance in our patient's care, that they ring ahead. They ring on the red bat phone from the clinician and say, we're bringing a 75-year-old lady. We think she's had a stroke. She's got right-sided weakness. It happened at 7:30. Here we come. So that means that the ED can call the urgent number at switch. The acute stroke team can be paged. All our pages go off, ding, ding, ding. Patient arriving in 10 minutes in ER1, and we can go down and meet the patient at the ED triage before they've even come in the door. So here we are, the same idea of rapid speed. Now, because radiology also works with us and knows that this is urgent, by 8:20 we've actually already obtained a CT scan of the brain, which is our most important diagnostic test, and we have a radiology registrar standing there while we take the pictures and we look at it together, and we can see that this person doesn't have a hemorrhage in their brain. It looks like a stroke. We take them rapidly upstairs to the stroke unit, and the team is there. We have junior and senior doctors. We have a nurse practitioner candidate. She's almost a nurse practitioner. We have our stroke ward nurse who's in the acute stroke bay. We take some bloods. One of the team talks to the family. And on a good day, 8:45, we've started the clot-busting treatment. The nurses are working hard to make sure that blood pressure and temperature and blood sugar and things that are important to stroke are being monitored. We're watching a heartbeat and all is well. There's a bit of a theme, isn't there? So things are going well. She's actually improving with the therapy because it works better if you give it more quickly. So at 11 o'clock she's assessed by our team speech and language therapist, because we want to know if it's safe for her to have lunch, whether she can take her tablets or whether her swallow is affected. When things are stable and we know that blood pressure and everything is fine, she could go around to our lab about 2 o'clock in the afternoon and have her arteries in her neck assessed by our sonographer, who's also part of the team in the neurology stroke service. And later in the day, when things have settled down, she is assessed jointly by our physiotherapist and occupational therapist, who go to the bedside together because they have overlap and things in common with what they find in looking at the patient. Can she transfer out of bed? Can she stand? Is she able to use her hand now? And they find that she's actually much improved after therapy. They can get her out of bed. She's still weak and clumsy, and they think that almost certainly she's going to need a period of inpatient or rehabilitation in the home. Overnight, the nurses are watching her very carefully. We have a protocol for what needs to be done at what time after the thrombolytic therapy, and they know what observations they need to notify to the night cover, which is predominantly to do with blood pressure and changes in neurological status. The next day we do a ward round, and by routine, we take a nurse with us, and we try and include a member of the allied health team with us, and we find that she's much improved. And because she's been admitted on a Tuesday, so this is particularly lucky, our main multidisciplinary team meeting occurs later that day, and we determine that she's actually fit for discharge from acute care if we can find an appropriate rehabilitation environment. And the stars are aligned, and there's actually a spot in the rehabilitation in the home program for her, or on another week, depending on her circumstance, she may have gone to one of our inpatient rehabilitation units at Austin Health, but she doesn't need to be in the acute stroke unit anymore. And we've got various medical and rehabilitation follow-ups organised. So it's pretty slick. It doesn't always happen like that, but you can see that there are a whole lot of people who have been working together for the goal to get there. This is not something that's just about the doctors. It's about that whole chain of care from the moment that the husband recognised that there was something wrong. So what I'm going to do is talk a little bit about the acute stroke team that we have at Austin Health, and there are really two components to our team. And I'm going to start off by really talking about the SWOT element, what we've called the AST in our environment. And the SWOT team, and I wasn't actually sure what that stood for, but I knew what it meant, but it actually means Special Weapons and Tactics, which you probably all knew. But this is us, and the notion is that the acute stroke team goes to where the patient is, scoops them up, and applies their special weapons and tactics, which in our context is the ability to recognise and rapidly diagnose, interpret the CT, and provide the treatment as rapidly as possible. And the members of the SWOT team are a neurologist leader, and we'll come back to this. I think you need to have an effective leader who is a senior person. We have a registrar and an intern. We have a stroke nurse practitioner. She's a candidate, but she's almost a stroke nurse practitioner, and I'll talk about her role, but it's fundamental. And we have another senior stroke nurse on the team. And occasionally our team is swelled by having a research fellow and a clinical trials nurse, because I think that good clinical care, certainly in my world, is intimately linked with conducting research. So how did we come up with our SWOT team? And here I'm talking about this very early acute element of our team. Well, back in the early 2000s, thrombolytic therapy, clot-busting treatment for stroke, was licensed by the TGA as a treatment for ischemic stroke. And at that time, we weren't actually, even though the treatment was licensed, we didn't have very good established protocols. We weren't treating too many people. And so in 2005, we decided we had to fix that. We had to find the patients who were eligible for treatment, and we had to treat them. And we also had to treat them quickly. So the first thing we did is we developed a multidisciplinary working group, which included ambulance, so outside of the hospital, as well as consumers, and included all the components of the team that we've already talked about. So emergency department, radiology, nursing, intensive care, because we're dealing with acute people, subacute care, the whole spectrum. And we sat down in a room and we talked about the barriers to doing this. We had a whole lot of education and training, including mock calls about how to do the processes and the procedures and who does what. We set up a way of ongoing review of outcomes and time, so we do this on a monthly basis in our multidisciplinary team meeting. And as you can see, back in 2004, even though the treatment was licensed, we only managed to treat 10 people, which wasn't right because we were seeing hundreds of patients with ischemic stroke. But with this process and this team in the approach I've described, in 2005, just by having a team rapid response, we treated 27 of our 224 calls, so a more than doubling, nearly tripling of the number of patients. And just with this intervention, we markedly reduced our median door-to-needle time, which is really relevant for patient outcomes. And some of the times here were very fast, even though we still had some long times. And I have to say that there were marked benefits, which are really difficult to quantitate, about interdepartmental relationships and team morale. So we also did some more formal evaluation of whether there were other benefits of this SWAT team being introduced. So we had a retrospective before and after audit, and what we did is we looked at a group from 5 months before the AST in 2004 and then 5 months afterwards. And we have a stroke database in our unit at Austin Health, so we looked at data from there, but we also looked at the patient management system in our hospital for various factors that you can see here that we were interested in. And we were particularly interested whether this approach would, we did indeed change these door to CT times, whether we affected mortality and length of stay. And as you'll see here, the patient characteristics of 350 odd people are similar before and after the AST. ICH stands for intracerebral hemorrhage, diabetes, atrial fibrillation, and you can see that the patients look pretty well the same in the before and after cohort. And this is a really important slide that I'll just talk you through. So this is before the SWAT team, after the SWAT team, LOS length of stay. And you can see that with this intervention of going to the emergency department, identifying and treating people, that we're able to show a marked reduction in our median length of stay. That's astounding. Deb's making a nice face here, but it really is astounding. And what we think this is due to is that this is bringing that definitive diagnosis right to the front door of the hospital and initiating definitive treatment and a plan for a disposition of the patient within the first hours that you've seen them. We also, as we would expect, because we're trying to treat people that requires a CT scan to decide if you can treat them, there was a marked reduction. And this is looking at every single patient who's coming to the door. Remember, we can only treat those people with our rapid therapy who are arriving sub 4.5 hours, but this is looking at an effect on our total treatment of patients. And overall, our median time to get that definitive scan has come down remarkably. Now, what we didn't do is make any change to the median door to stroke unit time. And we weren't actually setting out to do that. I think we were thinking it would change the other processes in the hospital of bringing the patient up to the ward, but in fact it didn't make a difference there. But to be fair, that wasn't what we were targeting. At this stage, we were giving the thrombolytic treatment in the emergency department before going up to the ward. But what we did find is that in a multivariate analysis, looking at the things that predicted the need for rehabilitation rather than home, the introduction of the acute stroke team was helping patient outcomes. And I haven't got the slide, but there was no impact on mortality. So our conclusions from the introduction of the SWAT team is that it helped us do that initial investigation more quickly, it reduced our length of stay, it did help outcomes, we didn't affect mortality, which I don't think we would expect to, and we didn't manage to change getting people out of the emergency department, but that wasn't our focus. So we didn't stop there. We were able to progressively reduce our door-to-needle time by focusing on our processes over a number of years. But in 2010-11, we were very lucky to get some more money via the Victorian Stroke Clinical Network, and we wanted to see if we could improve how we got out of the emergency department, because I don't know how it is in dentistry, but in the acute medical health sector, we are pressed in the emergency department and we have to get people out of the emergency department or ambulance are overflowing. So we wanted to try and give our thrombolytic treatment much more quickly. We wanted to get our patients up to the stroke unit and we wanted to pull patients out of the ED quickly. So we tried to do that. So again, how we did this is we had a multidisciplinary committee. You have to listen to everybody and why they're worried about the things that you want to do and what the solutions are. We had a protocol that everyone agreed was fine, and this was with a very strong safety focus. We wanted to make sure that the patients were viewed to be safe before they went out of the emergency department. We monitored our medical emergency team and code blue activations to make sure that we weren't having more of them. And we started out by having the protocol just in working hours so that everybody's on deck and you can make sure that it's safe. There was heaps of education. Our stroke nurse practitioner candidate was in charge of this. There were simulation labs. The nurses had lots of hands-on practice at what they should be doing, the sort of assessments they should be doing, knowledge about the medication, and this went on for some months. And then we did a before and after evaluation, including staff satisfaction. So, you know, things are disappointing. We didn't manage to decrease our door-to-needle time much from where we were, but it was just as safe and it wasn't worse. So we were pulling people out of the emergency department, taking them to another place, and we didn't lose time. And we felt in retrospect that we didn't manage to overall change our door to stroke unit time because we weren't giving the less urgent admissions high enough priority, and that was an issue for our medical staff getting to the emergency department and seeing those less urgent patients. However, we managed to reduce our time in the ED, this is overall, and saved 57 hours of occupancy of resuscitation rooms, and that's truly meaningful when you've got ambulances banked up. But we did manage to find that if we were going to thrombolyse them, our median ED to stroke unit time was 45 minutes, which is just amazing, and 4.4 hours for other people who were fast-tracked. And we had some door-to-needle times that were sub 30 minutes, so we could do this more quickly but not consistently. No increase in METs or code blues, and importantly, very high level of staff satisfaction. There was a lot of concern of our ward nursing staff that this was scary and that these patients were scary and they wouldn't manage, but in fact what has happened is that the nurses feel as though they have much greater skills and ability to provide care for stroke patients. It's been very positive. So what I want to move to now is to talk about the broader work of the stroke team, which goes beyond those first couple of hours in the emergency department. And in going to talk about the broader team, our team goals have always focused on the patient as an individual, but there are many drivers that are generic for the way our team and the processes of the team works for each patient. And I'm sure you'll see them from what I've said so far. So we have time-dependent therapy, so we have to have a rapid system. We are very much pushed by ED time targets in our world these days. The stroke unit's the best place for patients to be. I don't have time to tell you about stroke unit care, but there's very good evidence that what we do in a stroke unit is very beneficial for outcomes. We also want to get people out of hospital as quickly as we can, but we want to give them the most appropriate rehabilitation within the resource constraints, so with a consideration of the individual needs. So who are the broader team? So we don't take everybody on our team down to the emergency department. There's too many of us as there is on some days. But as well as the rapid response SWAT members, we have a team with physiotherapists, an occupational therapist, speech pathologist, dietitian, social worker, neuropsychologist, plus we consider the wider members very much part of the team and acknowledge them when we're talking about how we're going. So who does what? I've already mentioned this. There needs to be a leader. I'm the leader at the Austin, and I don't in any way want to blow my own trumpet, but I think that it's really important to have a leader who's senior and who's seen to be someone who really knows what's happening in that particular area. You can't expect that this system will work if it's down to the most junior intern to be leading it at the coalface. You need defined individual roles related to craft. So in our system, the speech pathologists are the experts in assessing swallow, and that's something that they do when they're around, and they tell us a lot about that. And our advanced practice in speech pathology has learned to use the fibre optic endoscopy to look at swallowing that Brendan was talking about before. And she's much more expert at assessing swallow than I am, which would have been the traditional view that doctors are good at assessing swallow. We have physiotherapists that is most interested acutely in the gait, but importantly, we acknowledge that we have shared roles that cross craft groups, and people accept that. So nurses, our nurse practitioner and our registrar are just as important in making the initial diagnosis in the emergency department. Only this week, registrar missed a very important stroke mimic. Nurse practitioner went to see the patient and made the diagnosis. This is a highly skilled nurse who knows a lot more than the most junior doctor who's coming onto the team who has the role. Nurses also assess swallow via protocol and then refer on to the speech pathologist for the difficult assessment or for more detailed prognostication. And as I've already said, our physiotherapists and our occupational therapists work together. And this is all in the context of agreed protocols. These are not enforced protocols where we say, you'll do this. This is about the team agreeing about who does what and who's responsible for what. So why have a multidisciplinary team? Well, this is easy from the stroke perspective because clearly in our literature and research, having a multidisciplinary team is a key element of providing organised stroke care in the stroke unit context, and there is very good evidence that this approach reduces length of stay, gives benefits for outcome and mortality, and it's been tested against various more disorganised ways of providing care, and it is superior to all those ways of doing it. And going along to see patients all scattered around the hospital for stroke is not nearly as effective as bringing them all together. And I think in our area that's acknowledging the extreme importance of the nursing skills. Okay, the benefits of an early rapid response. I've touched on most of these, but making that rapid correct diagnosis I think is really important about getting people through the system and out the door, reducing time in ED and reducing length of stay, and for us, the shorter time to deliver something that is time dependent for efficacy. So what, from my point of view, are the key hallmarks of an effective multidisciplinary acute stroke team? And I love my team. They're a fabulous group of professionals, and I think they acknowledge I'm their leader, but we have respect for everybody's skill on the team. We're all working towards the same goals, so we meet together. And when we talk about multidisciplinary, I thought it was important to say that we're not just talking about care goals, we're talking about everything we do as a unit. So when we meet with our team and are looking at planning care for patients, but we involve our allied health and nursing staff in meetings with family about prognosis and care goals. It's not a medically driven exercise. Our education is all multidisciplinary. It's not just for nurses or just for allied health. All our protocols are multidisciplinary. We do the research together. We look at our outcomes and quality reviews in a unit meeting that brings everybody together, and we have team goals and celebrations, which I think are really important. And one of the things that we've had over the years is there's daughter needle time medals, and have had sort of ceremonies. Now, we've gone off the boil with this because we were doing it for a long time, but what we did is the team on the day that had done the best daughter needle time over a period of 6 months, we'd have a bit of an award ceremony and you'd get one of these awarded, and this is very special. So, but including the ambulance guys and the ED and the radiographer, not just our core team. And the other thing that's become part of the culture of our team is the intern cake competition. I don't know what the equivalent of the intern is in your world, and there's a prize for someone who can tell me what this cake shows, because this is specialist knowledge. I'll tell you. So this is one of the best examples recently, and this is actually a very excellent diagram of the blood supply of the brain. Looking at it from underneath, this is the circle of Willis. So the basilar artery, vertebral arteries, middle cerebral arteries, anterior cerebral arteries. Beautiful, really. It tasted good too. So just, I'm nearly finished, but I just wanted to, again, it seems like perhaps I'm playing myself up, but I think that leadership is really important. And the things that I think are important is that you have to be present and hands-on. I don't think you can be a leader of a clinical team like this and sit in your office and send emails. It just doesn't work. You have to be down there and be leading by example. There has to be some sort of X factor, and the units that have done the best research to show how teams work in my world are all led by charismatic people who are wanting to do research and improve outcomes for people. So you need someone like that. And you really need that senior person to be chairing the multidisciplinary meetings. Again, you lose your way if you delegate that to a junior person who just doesn't have the ability to make decisions. So this is just some of my favourite stroke enthusiasts around the world, and you'll see there's a good mix of men and women, so that's good, and young and old. So what are the enablers? I think a hands-on leader, for us having a geographic home is important. I think the team has to have frequent face-to-face contact together. You need executive support in your health service for advanced roles as well. So you might have an idea about how to do it, but you've got to have engaged your hospital executive to support you. You need to respect all your team members and train your juniors that you're training to understand the expertise of the members of the team, because that's often not well taught when we're coming through the medical and nursing system, what other colleagues can do. Stable senior members are important. Your multidisciplinary protocols need to have safety nets. So this is all not free form. You've got protocols that are driving how we behave. At the same time, you have to be flexible. I'm always looking for innovation. We have a fantastic dietitian on our team who is often the person who has the best idea about something we're struggling with. So, you know, she has only a small allocation of time to our team, but she's very engaged. And I think a culture of learning and research that's embedded in your clinical practice, where you constantly review performance and want to improve, is the way you have a great team. So, and the reverse of that, and Brendan talked about this a bit before, is that you do need leadership. If the team's changing and you're relying on inexperienced people, that's a problem. And you do have to get to the point where you truly have respect for the people who are not from your group, that they are really value adding. And I tell you that this week my junior registrar was incredibly embarrassed that they had not taken the time to properly go through a patient where the diagnosis was obvious, but it was most obvious to the nurse practitioner. So the team works together and we all learn from each other. So I think that's the final thing. Now, this is just an old slide. I put this in for Leanne. This is from when we did our first work for the acute stroke team, and these people have all gone on to bigger and better things. But you need an emergency physician, you need a stroke nurse, you need a stroke doctor, you need the radiographers to help you. It's a team effort. So thank you very much.